We've created this animated video with the intention to show what the journey for assessment, diagnosis and treatment for Tourette syndrome and other tic disorders can look like for patients in the UK. This video talks about Tourette syndrome, but the information can be applied to all tics and tic disorders, especially given that the clinical pathways and treatment options are the same for all tic disorders. From working with patients and listening to their stories, it seems to us that this journey can be straightforward or can be very complicated, with patients unsure of where to turn in order to access services. It's hoped that this video can help show the complexity of this journey, which will highlight how services and clinical pathways vary from place to place in the UK. Another aim of this animated video is to show what a gold standard or best practice pathway might look like, and so in this we make suggestions to improve patients' access to healthcare services. So let's start with how someone might go about getting a diagnosis of Tourette syndrome or another tic disorder. Getting a diagnosis can lead to greater understanding of the condition and help the patient get access to specialist healthcare and treatment, support networks and other services. And in the case of children and young people, can also help them in getting access to extra help and support at school. Let's have a quick look at what tic disorders are. Tic disorders are neurodevelopmental conditions characterized by tics. These are involuntary sounds, typically referred to as vocal tics, and involuntary movements, often called motor tics. Tics may wax and wane in frequency and severity over time. There are several types of tic disorders. Transient tic disorder or provisional tic disorder refers to when the patient has motor and sometimes vocal tics, which only last for a few weeks or months. Chronic tic disorder refers to where single or multiple motor or vocal tics have been present, but not both types of tic, and have been present for more than 12 months. Tourette syndrome refers to where the patient has multiple motor tics and one or more vocal tics, and have been present for more than 12 months. Tics usually first appear around the age of 5, but it can be younger or much older than this. Tourette syndrome is often associated with co-occurring conditions such as attention deficit hyperactivity disorder, or ADHD for short, and obsessive compulsive disorder, known as OCD for short. These conditions often overlap and run in families. The clinical pathways, management, medication, and behavioural therapy options are the same for all tic disorders. At the start of the journey to diagnosis, most often parents typically take their child to their GP after noticing involuntary sound and movements, known as tics, in their child. The parents may have already contacted a support association such as Tourette's Action or other local support groups, or looked on the internet for information. The response they'll receive at a GP appointment all depends on how much their GP knows about tic disorders and Tourette syndrome. This might be a frustrating moment for the parents and child. Often GPs won't take initial action, but will ask parents to engage in a period of watchful waiting to monitor the progression of tics. For many children, tics usually disappear on their own, while for others they may persist. During this time, parents might find it useful to keep a diary to note down the different movements and noises, when they seem better and when they seem worse, and how they affect daily living. Parents might also find it helpful to record the tics on video, so that parents can present this, along with a written diary of symptoms, to their GP or healthcare professional during their appointment. GPs act as gatekeepers who refer patients for further assessment. We'll describe in a little bit who's involved in diagnosis. So let's talk about local services first. Some people are referred to community specialist services initially for an assessment, and so may be assessed by a community paediatrician, a child and adolescent mental health services professional, or CAMS for short, or a neurologist. Sometimes we've heard that CAMS services refuse to see patients with tics, and have said that because tics are neurological in nature, it means they can't be treated by CAMS. Some CAMS services will see children with tics, and this may be the result of a better understanding and training in this area. Clinicians can be trained in behavioural therapy, which they can offer to their patients to help them manage their tics, and this can be done alongside treating them for co-occurring conditions. Whether someone gets treated in their local area depends on who's commissioned in that local area to treat Tourette syndrome and other tic disorders. There are a number of health professionals who are involved in the diagnosis and support of Tourette syndrome and who might be available for patients depending on what's available in their local area. These include neurologists, psychiatrists, pediatricians, clinical psychologists, educational psychologists, occupational therapists, special educational needs coordinators within schools, called SENCOs for short, specialist nurses, and speech and language therapists. Another way that children might start this journey towards diagnosis and treatment is via school. It might be that a teacher or another staff member, a health visitor, educational psychologist, SENCO, school nurse or specialist teacher notices a child's tics. At this point, parents or caregivers would be contacted and this issue would be discussed. Parents might take their child to their GP, or some school staff may be able to refer directly to CAMS. Parents might also seek out private healthcare for Tourette syndrome or tic disorders, for example to access treatment such as behavioural therapy for tics. This may be suitable financially for some families, but is certainly not the case for the majority. There are also national and specialist services for tic disorders like Tourette syndrome. If there is a specialist Tourette syndrome service in their local area, then the GP can refer there providing they're aware of it. If there are comorbid mental health difficulties such as anxiety, depression, self-harm, trauma and attachment issues, which may further complicate the diagnosis process, then GPs could refer to community CAMS, but it would be worth checking if local GPs can refer to any of the local specialist services. Factors such as location, access to services and whether there are service level agreements depend on whether a referral to specialist services goes ahead. This would be decided on by managers and the clinical team. There are national and specialist services for Tourette syndrome at several places in the UK, including at Evelina London Children's Hospital, Great Ormond Street Hospital and Queen's Medical Centre in Nottingham. There are also adult services at the National Hospital for Neurology and Neurosurgery in Queen's Square in London and at the Department of Neuropsychiatry, Burnham and Solihull Mental Health Foundation NHS Trust. The St George's Tic Disorder Clinic in London is the only one that sees both children and adults. Once seen by a specialist services like those mentioned, the patient will tend not to be referred anywhere else but be discharged back to local services such as CAMS with the recommendations from the specialist services. So in conclusion, it seems that in local areas clinical pathways may sometimes depend on the GP's knowledge, but mostly it's due to the local agreed referral pathway which affects a patient's journey to getting their diagnosis and being offered treatment. The majority of children with tics can be treated in paediatrics with some basic psychoeducation and reassurance to the family that having tics is not a big deal for a lot of kids. Outside of local areas, the GP may be able to refer to a specialist Tourette syndrome service not in their local area, but the stepped model pathway for diagnosis is usually from GP to paediatrician. It's likely that most specialist services do not accept referrals from GPs directly and only accept referrals from paediatricians or local CAMS services. In certain cases, some specialist clinics may take referrals from GPs out of area where there is confirmation that local services are able to carry out the specialist services recommendations. Therefore, someone may be seen at a specialist clinic and then be referred back to the local services for treatment and management in their local area. What we do know is that patients feel very frustrated if they end up visiting many professionals and are bounced around between services. If they'd been seen by the most appropriate healthcare professional sooner rather than later, the diagnosis could be quicker and treatment offered sooner. We've heard from patients who have had to travel very far in order to get a diagnosis and to access treatment, sometimes travelling across the UK and between countries in order to do so. One complexity seems to be that Tourette syndrome is a neurological condition, but treatment and management can be carried out by mental health professionals, and that many of the commonly co-occurring conditions such as ADHD and OCD are classed as mental health disorders. We know also that patients would like to access a variety of treatment options, not just medication, but also to behavioural therapy. This is difficult as there is a lack of trained therapists in the UK. Hopefully, with the increased use of telemedicine, people from around the UK have a higher likelihood of being able to access behavioural therapy for tics no matter where they live. Earlier on, we mentioned the idea of what a gold standard pathway or best practice might look like. The gold standard treatment when there are complexities with co-occurring conditions present such as ADHD and when there are problematic tics would be to get these patients referred to a specialist service and then discharged when the support has been given. The discharge back to local services should be to a health professional who has the option of prescribing medication to the patient and support the local school with information and refer into specialist services if more behavioural therapy or consultation is needed. Paediatricians and community CAMHS departments generally fulfill this criteria. Best practice would be to have as few steps as possible, with a referral back to a specialist clinic with the aim being for the specialist services to be involved for as little time as possible and be able to reach the most amount of children. There are complicating factors where certain medications cannot be prescribed by GPs as they are not licensed to do so. Something that would help here is producing NICE guidelines. These are clinical guidelines which set out the most appropriate clinical care for patients with a specific disease or condition. They are based on the best evidence available of what works and what it costs, and provide recommendations on how to best identify, refer, diagnose, treat, and manage patients. They are designed to drive measurable quality improvements in a particular area of health or care. For Tourette syndrome and tic disorders, NICE guidance could help GPs as they would give clear recommendations as to what local services are supposed to provide and when to refer to specialist or national services. We hope that this video has shown some of the complexities of what the journey can look like for patients in the UK who have tic disorders including Tourette syndrome, and how accessing services and clear clinical pathways vary from place to place. We suggest that what is required is to help local services for those patients with tic disorders by increasing the number of specialised psychologists, therapists and paediatricians. By increasing the capacity of local NHS services to see patients with tic disorders, especially by CAMHS and paediatricians, they would be able to treat tics and co-occurring conditions at the same time. We would suggest that behavioural therapy and psychoeducation around tics could be delivered by telemedicine and group interventions using remote access and online treatments. Importantly, also providing supervision expertise to trained CAMHS professionals and paediatricians would be a helpful factor in their confidence and ability to treat and manage tic disorders. Our recommendations would be more awareness of what tic disorders are and how to treat them, offer training to those who are well placed to see patients with tic disorders, such as in CAMHS and paediatricians, more use of telemedicine and group interventions to deliver behavioural therapy and psychoeducation around tics, the creation of NICE guidelines giving clear recommendations as to what local services are supposed to provide and when to refer to specialist or national services with an aim that all patients can receive the same healthcare services. A future aim could be for specialist commissioners to provide a sustainable funding model for services. In our view, NICE guidelines for Tourette syndrome and other tic disorders would make a massive difference to helping the pathways of diagnosis and treatment for patients. Tourette syndrome is not a rare condition. It has a prevalence of roughly 1% in the UK, around the same as autism, and so affects approximately 1 in 100 schoolchildren. This number is much higher if we include all the tic disorders together. Patients with tic disorders should not have to experience a lottery in terms of their diagnosis and care depending on where they live in the UK. They are entitled to receive the healthcare support, treatment and management they need to help them live their lives to the full. If you're looking for advice about Tourette syndrome, please see the podcast and topic guides produced by ACAM and also look on the Tourette's Action website. If you're a clinician and interested in undertaking training for behavioural therapy for tics, please contact Shoreditch Anderson at the following email address: